Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on the International Phase 2 Highdes trial is hosted by the AST's Kidney, Pancreas, and Transplant Pharmacy Communities of Practice. Our speaker today is Dr. Bonnie Lonze from the New York University Langone Transplant Institute. Our moderators today are Dr. Edmund Huang from Cedars-Sinai Medical Center in Los Angeles and Dr. Christopher Ensor from AdventHealth Orlando. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note that your lines have all been muted so that only presenters can be heard clearly for the archived recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will answer them either individually offline or post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of the Journal Club today, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Huang and Ensor, to begin our presentation.
Thank you very much, Brian. As Brian mentioned, my name is Chris Ensor. I'm the clinical chief and manager for academic affairs in the Department of Pharmacy at AdventHealth Orlando. I practice with the lung transplant service here, and my research interest is in highly sensitized candidates and antibody rejection after transplantation. Welcome everybody to the session. I'm joined by the esteemed Ed Huang and Bonnie Lonze. I will turn over to Ed to introduce himself and Bonnie to our audience.
All right, welcome everyone. It's a pleasure to be here. Thank you to the organizers for allowing us to present this to you today. And I'm Ed Huang. I'm a transplant nephrologist at Cedars-Sinai Medical Center, and I'll be one of the co-moderators today. I'm going to introduce our speaker. It's Dr. Bonnie Lonze. She's an assistant professor of surgery at the NYU Langone Transplant Institute. She's an MD PhD, receiving both of her degrees at the Johns Hopkins University School of Medicine. She also completed her general surgery residency there and an abdominal transplant fellowship at Johns Hopkins, where she then stayed on as a member of the surgical faculty there before moving to NYU in 2016. She is the vice chair of research at NYU, involved in the design and execution of their clinical trials for their solid organ transplant patients at NYU. And her publication record is quite extensive, and she's been particularly involved in a lot of the early work on imlifidase, at least in the clinical trial experience. And so it's a pleasure to have her here to be able to share over the experiences with imlifidase in kidney transplantation. So before we get to the main presentation, Chris and I are going to do some introductory slides to set the stage for the topic today. And so I'm going to talk for a few minutes on the rationale for desensitization, and then Chris will give some of the basics of how imlifidase works for desensitization and transplantation. So let's get started. Next slide. So when we see a patient for transplant evaluation, we will talk to the patient about their options to either receive a living donor or a deceased donor kidney transplant. And for the vast majority of these patients, they will be receiving an HLA-compatible donor. But for patients who are highly sensitized, the reality of having to consider an HLA-incompatible donor increases, so that patients who have an HLA-incompatible living donor have the option of either participating in a paired kidney exchange program where they can swap donors to find a more compatible transplant, or they can proceed with that donor with an HLA-incompatible transplant under the setting of desensitization. For patients who don't have a living donor, they will be waiting for a deceased donor kidney transplant, and their options are either to wait for an HLA-compatible deceased donor, but if the patient is sensitized enough, they could be waiting for years, or they can move forward with an HLA-incompatible deceased donor kidney transplant. Again, that would need to be done under desensitization. Next slide. So although I think that it's important for us to discuss all the transplant options for a patient, it's actually, in my opinion, that it's more important for us to set realistic expectations for those patients for what they may be facing as they wait for a kidney transplant. So although I think we all recognize that as patients become more sensitized, that more donors are required in order to find a compatible crossmatch, recognize that you can actually quantitate and provide an estimate of exactly how many donors are required, and that's represented by this mathematical equation on the bottom left-hand column. And so if you plug in the numbers and tabulate the output, you can see here on the right, as the CPRA approaches 100%, that the number of potential donors increases dramatically, so that if you have a PRA of 99.9% or above, you would be estimated to need approximately 3,000 match runs in order to find a compatible kidney transplant. Next slide. So recognizing the HLA incompatible problem, there was revisions made to the kidney allocation policies in 2014. And these policy changes focused on increasing priority for patients, particularly who had a PRA of 99% or above, where they were awarded a high number of waitlist points, and they were prioritizing the allocation sequence. So you can see here on the right that nowadays that patients who have a CPRA of 100% are going to receive first priority for all local, regional, and national kidney offers. Next slide. And so the early results of the kidney allocation system after it was implemented saw this marked increase in the number of transplants that were performed in patients who had a CPRA of 99% or above. And so many looked at this early data and declared that the kidney allocation system was a success and that it met its intended effect of bringing more transplants to the highly sensitized population. And there were some members of the transplant community that went so far as to say that there was no longer a role for desensitization with the revised allocation policies. Next slide. But I think that some of this sentiment was misguided, and I think, in my opinion, was somewhat hurtful for the numbers of patients who are waiting for kidney transplants. Because even if you look at the data in finer detail, you can say that even early on that the kidney allocation system did not benefit all sensitized patients. In fact, if you looked at patients who had a PRA of 99.95% or above, there continued to be a large disparity in the number of transplants that were performed compared to their representation on the wait list. Next slide. And so even after the early effects of the kidney allocation system stabilized, and we looked at a cohort of patients who were waitlisted later, this was data from a cohort of patients who were listed in 2016, we could see that transplant rates dropped considerably after you reach a CPRA of 99.5% or above. And if you have a PRA of 99.9% or above, the transplant rates are lower compared to lesser sensitized or unsensitized candidates. Next slide. And so what you have here on the right is an accumulation of patients who have a PRA of 99.9% or above, where these patients are now more likely to be either removed from the waitlist or to die rather than receive a deceased donor kidney transplant. So what we're seeing here is signals that we cannot rely on allocation policy alone, and it's a subset of patients that you may need to start considering HLA incompatible kidney transplants. Next slide. So what about living donation? Next slide. So I don't think there's any debate here that if a patient can get a living donor transplant, that would be the preferred method of receiving a kidney transplant. But for patients who have an HLA incompatible donor, their options are to participate in paired kidney exchange. But I think that there are some misconceptions in the transplant community that it's fairly simple, that you just enter a patient into a paired exchange program and they can come out with a compatible donor. But realize that kidney paired exchange is hardly ever successful in the most sensitized patients. And so this is data from the SRTR. This was published by the Hopkins group looking at transplant trends pre and post KAS. And if we focus here on the right in era 3, so that's post KAS data, you can see that for patients who have a PRA of 98% or above, that living donor transplants are hardly ever performed. They only account for 4% of all transplants that are performed in this population. And for KPD, counts for even less. Only 2% of transplants that are performed in patients with PRA 98% or above are in the form of transplants that were facilitated by paired exchange. Next slide. And so we know also from National Kidney Registry data that it's not only PRA that matters, but it's blood type. So that if you have a combination of blood type O and a PRA of 98%, only 10% of patients find a suitable donor through paired exchange over the course of a year. Next slide. And this data is replicated even from other kidney paired exchange registries. This is data from the Alliance for Paired Donation, where you can see that for CPRA 95% or above, you're more likely to remain waiting for a suitable donor through paired exchange or to be withdrawn from the paired exchange registry or receive a deceased donor kidney transplant than you are to receive a transplant that was facilitated by the paired exchange program. So paired exchange is hardly ever successful for these types of patients. Next slide. And so the question comes up, well, what do you do about the 2,000 patients who have a PR of 99.9% or above and are waiting for a kidney transplant? And if you do the math and you estimate that each of these patients needs approximately 3,000 match runs in order to find a compatible kidney transplant, you would need 6 million match runs in order to meet the needs for all of these highly sensitized patients. And so what I would argue is that we need to shift our focus from looking at only HLA compatible transplants to now expanding the focus to HLA incompatible transplants and considering desensitization. So now that I hopefully have convinced you of the need for desensitization, I'm going to turn it over to Chris, and he's going to discuss some of the mechanisms involved with imlifidase.
Thanks, Ed. I'm very briefly going to describe imlifidase and mechanism of action and the potential benefits mechanistically to these patients, as Ed is talking about, and then Brian will jump right into the journal club itself. So imlifidase is a recombinant cysteine protease derived from Strep pyogenes. I think all of us are well aware of where it comes from at this point, but essentially works in a two-phase cleaving process to scrap the Fab portion and the FCE portion of a complete IgG molecule in an effort to decrease binding to the Fc gamma receptor on immune cells. Next slide. And this just describes the potential mechanisms that could be associated with such cleavage. And so if you look at the slide from left to right, you'll notice that you have a full antibody that is uncleaved. And generally speaking, these types of interactions could result in complement positive, CDC positive, and ADCC positive interactions with the allograft through the Fc gamma receptor. The first cleavage of the FC portion away from the Fab portion could still result in some binding to the Fc gamma receptor, which may or may not result still in antibody-dependent cellular toxicity to the allograft itself. The second series of cleavage to completely remove the Fc portion from the Fab portion of the antibody, IgG antibody, will inhibit the binding to the Fc gamma receptor and block complement-dependent cytotoxicity as well as ADCC. On to the next slide. And so what this yields for us is on the top of this slide is sort of normal function of antibody responses where you have binding of donor-specific antibody to HLA molecules on the surface of the allograft, binding complement, creating CDC toxicity at the allograft itself, killing allograft cells and experiencing antibody rejection. Likewise, the binding of the Fc gamma region binds also to the NK cells, resulting in ADCC. Now, if you use imlifidase and cleave off the Fc portion from the Fab portion of the antibody, you will not bind complement 1q to the antibody fragments themselves. So you will not have complement-dependent cytotoxicity. Likewise, you are likely to block the binding of NK cells to antibodies themselves by the Fc gamma receptor, which downregulates or blocks the likelihood of ADCC occurring to the allograft itself. So the potential benefits of imlifidase are clear mechanistically from this rationale to desensitize the patients and remove the functionability of circulating DSA to bind human purified C1q, as well as minimize the risk of ADCC to the allograft. The problem that this poses, however, is it's an antibody-directed solution, and it still leaves the rest of the cellular infrastructure intact. And so there may or may not be a substantial rebound problem that Bonnie will describe in getting into the clinical trial journal club. And that's all for the mechanism.
All right. Well, thank you very much to the AST and the organizers for inviting me to talk about this paper. And thanks to Ed and Chris for those very relevant and nicely outlined background slides. And with that, we'll jump into this article, which was published in the journal Transplantation in the middle of 2021. Just quick conflict of interest disclosure. So I have received consulting honoraria from Hansa Biopharma, who produces imlifidase. for consulting in the design of a phase 3 trial related to this drug, but not related to what is presented in this paper. And of course, imlifidase is an investigational agent in the United States. There are no FDA approvals for its use. All right, so the rationale of this study, as we've just heard, is that despite the KAS, there is a large group of patients for whom HLA sensitization remains a significant barrier to transplantation, and for whom desensitization as it exists currently does not appear to be the answer. Imlifidase rapidly and efficiently cleaves IgG, and therefore it may offer a novel desensitization modality to help some of these patients. This was a single-arm, open-label phase 2 trial. This was an international study. It was conducted at 5 sites across 3 countries, and the sites are listed here. Our center did participate in this trial, so I'm familiar with some of the patients that went into it. It was, of course, approved by all the regulatory agencies and was registered on clinicaltrials.gov as listed. The primary objective of this phase 2 study was to test the ability of imlifidase to convert a positive crossmatch into a negative crossmatch within 24 hours. So the whole study should be looked at in the context of that being the primary objective goal. So I'll briefly go through the eligibility criteria and some of the methodology before we just sort of dive into the nuts and bolts of the data presented in this paper. So patients were considered to be candidates for the study. It was sort of a 2-stage enrollment process. So there was a pre-screening process where potential candidates were identified, and these included adult patients who were on the waiting list locally. And this, of course, implies that they met all criteria at the local site to be eligible for listing for a kidney transplant. Candidates also, if they had no living donor available, had to have failed a prior effort at desensitization. So that would typically be with high-dose IVIG and rituximab. Or if desensitization wasn't attempted in the patient because it was deemed unlikely to be successful due to the broad and strong sensitization of the patients. If the potential candidates had a living donor, they were considered a potential candidate if the crossmatch with that donor was deemed too strong to consider plasma exchange with low-dose IVIG as a desensitization modality that would be thought to have any possibility of success. Patients were actually enrolled in the study only at the time that an available organ offer was there. So either a living donor with a positive crossmatch, like we talked about before, or a deceased donor offer became available to the patient by way of the UNOS registry. Not only did the donor organ have to be available, but in order to be enrolled, there had to be a documented positive crossmatch test with the donor. And now, for purpose of this study, it wasn't specified whether it was a flow or a cytotoxicity crossmatch, just that one of the two or both needed to be positive. And that was a cell-based assay. It needed to be positive. All of the enrollment crossmatches were done in the local HLA labs for obvious logistical reasons. In France and Sweden, there were a few other specific enrollment criteria. So in France, there needed to be at least one donor-specific antibody with an MFI by Luminex assay of at least 3,000. And in Sweden, the patients were required to be on the waiting list for at least a year and were required to have a CDC PRA of greater than 80%. Patients were excluded from the study if they had received high-dose IVIG for waitlist desensitization within 28 days of enrollment, or if for some reason they had previously received imlifidase, which ended up being no one who was referred for the study. In terms of the methodology, just to get some of the definitions out of the way, how the CPRAs were defined in the eligibility assessments. This was done using the OPTN calculator with an MFI of 3,000 as the cutoff for entering an antigen as unacceptable. DSA rebound, which we'll talk about a little bit down the road, was defined as any donor-specific antibody that achieved an MFI of greater than 1,000 following imlifidase administration. DGF, pretty standard definition here, dialysis within the first 7 days post-transplant. The pathological analyses, so for diagnosis of rejection, there were local pathologists that were relied upon to make those diagnoses and direct treatment, but all of the pathology, the slides were reviewed centrally, and so the the final path from the protocol biopsies, those are all summarized and were read by a single pathologist, essentially. And eGFR for estimates of graft function were calculated using the MDRD formula. In terms of administration of the study drug, imlifidase was administered by intravenous infusion at a dose of 0.25 milligrams per kilogram, ran over about 15 minutes. There were pre-medications given, steroids and antihistamines in all cases. All patients who were enrolled received a single dose of the study drug imlifidase on day 0, that defined at the time point day 0. A second dose at the same dosage, 0.25 mg per kg, was able to be given within 2 days of the first dose at the discretion of the investigators. We'll talk about that more in detail a little bit as well. To judge the efficacy of imlifidase at cleaving IgG, specifically DSA, cross matches were performed before and after dose 1. And transplantation was proceeded to after the confirmation of a negative cross-match post-dose. And there's one little asterisk here, which is, this is the exception of Cedars-Sinai, which didn't wait for the cell-based cross-match to come back before judging whether it was appropriate to proceed to transplant. This decision was made based on a virtual cross-match in those cases. As far as immunosuppression management for these patients, there was an induction regimen, of course, for these highly sensitized patients. This consisted of pulse steroids in all cases, with the first dose being administered intraoperatively. Horse ATG, antithymocyte globulin, ACAM, at the listed dosage was an option for induction, and that was started intraoperatively. Rabbit ATG or thymoglobulin was not able to be used because rabbit IgG is actually cleaved by imlifidase as well. So if ACAM was not to be used, then the alternative was Campath or alemtuzumab, which was given in a delayed fashion on postoperative day 4. And again, the reason for the delay was because that humanized antibody would be susceptible to cleavage by the product itself. The choice of induction was site specific and had a bit to do with which agent was available at the varying sites. For maintenance immunosuppression, the protocol deferred to the local sites for their standard of care and what they thought was appropriate for the patients and what was tolerable for the patients. Built into the protocol were 2 adjunctive treatments that were designed to, or hypothesized to, minimize antibody rebound following imlifidase administration. And this was high-dose IVIG, 2 grams per kilogram, that was given starting on day 7, typically over a split dose, and rituximab at a flat dose of 1 gram, which was given on day 9. Infectious considerations for patients enrolled in the study: the standard anti-infective prophylactic agents for the specific sites were used for PJP prophylaxis, CMV, antifungal prophylaxis, and additional antibiotics were administered, again, sort of at the site discretion based on infectious diseases guidance for the duration of the hypogammaglobulinemia that was induced by the imlifidase administration. The endpoints for this study, as I mentioned initially, so the primary efficacy endpoint was conversion of a cross-match from positive to negative within 24 hours of receiving the first imlifidase dose. And this was met if all recorded cross-matches were negative, so flow and or CDC. Every cross-match had to be negative to meet this endpoint. And the secondary efficacy endpoints included donor-specific antibody levels at a whole host of time points compared to the pre-dose levels, graft function as measured by the eGFR, PK and PD studies for imlifidase itself, and then of course safety measures. This included adverse events as well as the development of anti-drug antibodies in the recipients. Data analysis, nothing fancy here, descriptive statistics in this small study. So the protocol looked like this for patients who were sort of going through this. So in the pre-transplant section there, that's where really the pre-screening was taking place. And the patients were able to enroll once a donor was identified and a quote unquote qualifying cross-match was performed and resulted positive. With that, the patients who were interested in enrolling were consented and imlifidase was administered following the consent. There were cross-match tests performed at 2 hours, 6 hours, and 24 hours following the first dose of imlifidase. So once a cross-match test resulted negative, then again, at the surgeon's and team discretion, the patient proceeded to transplant. And it could have been any of the post-imlifidase cross-matches that were negative that would permit proceeding to transplant. So there was a little bit of variability in the time frame there. Just a little footnote in terms of who enrolled living versus deceased donors. In France, there were living donors only eligible for this, living donor recipients only eligible. And then in Sweden and the United States, both living and deceased donors were used for the patients that were enrolled in the study. The induction immunosuppression, as mentioned, was either started intra-op if it was ZACAM or was given on day 4 if it was CAMPATH. And then the high-dose IVIG and rituximab as shown. And then the post-transplant surveillance, this really at that point became an observational study. And there were a lot of post-transplant donor-specific antibodies that were drawn for each of the patients at the listed time points. And the study duration here was 6 months. And at the end of that time point, a protocol biopsy was proposed for all of the patients. So this is a summary of the enrollment. There were 21 patients across all the sites that were assessed for eligibility. 2 were excluded, 1 due to deemed being unable to comply with the protocol, and 1 had both negative flow and negative CDC cross matches with the donor, so they had a compatible organ offer and hence weren't the candidate. So that left 19 patients who were enrolled and who received imlifidase. 1 patient was withdrawn after initiating the imlifidase administration due to a significant infusion-related reaction, and the dose was discontinued after about a quarter of it was infused. And again, that patient was withdrawn from the study, and so no data was collected from that patient. That patient also did not proceed to transplantation. 18 patients did proceed to transplant, and among those, 13 were deceased donor recipients and 5 were living donor recipients. So here's some characteristics of those who did enroll. The median age was 40 years old, 68% were male. Not surprisingly, in the bottom highlighted box here, a significant proportion of these patients had had a prior transplant. Some of the patients, I think 1 patient was receiving a 4th transplant by way of this study. Again, not surprisingly, many of these patients had spent many years on dialysis. The ranges are listed there. So among the patients who had had a previous transplant, the mean time on dialysis was 5 years with a range of 0 to 13. And among the patients who had not had a prior transplant, the mean time on dialysis was over 11 years. And that was largely driven by 1 patient who had been on dialysis for over 22 years. Many of the patients had failed prior attempts at desensitization. And just to kind of drive home the point that the enrollment criteria really allowed the study to capture the patients it was after, the median CPRA of the patients enrolled in the study was 99.8 with the range as listed here. The cold ischemia time on deceased donors relevant to the DGF discussion was significant, 27 hours with a range of 9 to up to 46. Most of the deceased donors would meet quote unquote standard criteria for donors. 1 of them sort of fell out of that and had some less typical characteristics. Some of the deceased donor kidneys were pumped, others not. And then just the distribution of the induction therapy choices. So the majority of the patients did end up receiving alemtuzumab, 78% versus 22% that received the horse ATG. The pre-dose cross matches. So this slide's a little bit confusing because not every single patient had every single one of these tests done, but every patient had at least 1 positive cross match test. And so the breakdown is kind of as highlighted as shown. So 7 of the patients had a T cell flow cross match positive. 18 of the patients had a B cell flow cross match positive. 2 had a T cell cytotoxicity cross-match test positive, and 8 had a B cell CDC cross-match that was positive. And again, this is prior to imlifidase administration. So just looking at sort of the breadth and the strength of sensitization of these patients, these graphs here sort of illustrate the immunodominant DSA for the enrolled patients and their strength and their class 1, class 2 assignment. So they are illustrating the number of patients. So in the graph on the left, so you can see there are 5 patients that had their immunodominant DSA was a class 2 antibody with an MFI of greater than 20,000. And then looks like another 2 patients had a class 1 antibody greater than 20,000 MFI. And just to drive home the point about the strength of these antibodies, these are some dilution tests. And so some of the patients, even at a dilution of 1 to 100, which is the gray bar here, some patients actually had MFIs in excess of 20,000 at 1 to 100-fold dilution of their serum. So, by all measures, these were very strong antibodies. The primary efficacy outcome, now getting into the results of the study. So in terms of how the primary efficacy outcome was met, so 17 out of 19 patients, or 89% of the cross matches, were converted from positive to negative within 24 hours of dose 1. So there were 2 instances where the primary efficacy outcome was not met. One was the patient who was withdrawn after the partial dose. And in a second case, there was one patient with a residual T-cell flow cross-match at 24 hours. But this is a little bit of a confusing picture because there were no DSAs that were detectable on the Luminex assay. So a technical failure, but this patient did actually end up proceeding to transplantation despite this positive cross-match. There were 3 patients who received the eligible second dose. And the second doses were administered in the setting of positive cross matches. Now it could be the 2-hour post-dose cross match or the 6-hour post-dose cross match that dictated when the second dose was administered. And kind of the timing of that depended on whether it was a deceased donor and there was concern for cold time accrual, or whether it was a living donor and there was less concern. But in general, all the patients that received a second dose had a positive cross-match at 2 hours. 2 of them had a positive cross-match at 6 hours. In the first case, the 6-hour cross-match had become negative, but the decision to administer the second dose was based on the 2-hour positive cross-match. That having been said, all of the patients who received the second dose did go on to ultimately have negative cross-matches. Looking at the effect of imlifidase on the donor-specific antibodies, this is sort of a histogram here, and what I have some annotations to help understand these hopefully a little bit more quickly. But so this is the numbers of patients which I've entered in the pink here that met this criterion of having all of their individual DSAs be less than 3,000 MFI, and at what time point related to imlifidase dosing that occurred. So there was one patient that actually, even prior to receiving imlifidase, it seemed that all of their DSAs were less than 3,000 MFI. Nonetheless, that still had resulted in a positive cross-match. But the rest of the patients achieved that endpoint sometime after imlifidase dosing. Most of the patients, so 14 of the 18 patients, met this criterion within 2 to 6 hours after imlifidase dosing. And then a few other patients met this sort of goal in a somewhat delayed fashion. And then just looking at the composite kinetics and the elimination and rebound kinetics of all of the patients. So this is the box plots here represent all DSAs, all patients. And you can sort of see how rapidly the HLA antibody or the DSAs are eliminated following the administration of imlifidase compared to the pre-dose. Other important takeaways from this are the rebound. As Chris had indicated, this is not a durable phenomenon, the loss of IgG, which is both good and bad. But the plasma cells eventually begin to repopulate the serum with IgG, and that rebound generally occurs starting on day 3 was about the earliest that it was seen, and the rebound is generally complete, so to speak, by about day 14. There were 2 patients, however, that had no rebound of any DSAs, and if you recall from one of the earlier slides, it was a very low threshold to be considered having had a rebound. All that was required to meet that criteria was developing an MFI of greater than 1,000. So there were 2 patients that never had any DSAs achieve an MFI of greater than 1,000 after imlifidase was dosed. I mean, the other thing that's sort of important to take away from this is that even though rebound occurred in most of the cases, the levels to which the antibodies rebounded generally weren't on pace with the levels of the antibody, at least measured by DSA, prior to imlifidase dosing. As far as how the DSAs behaved in the long term, at the end of the study, there were 11 patients that had no DSAs that were in excess of 3,000 MFI. There were 6 that had at least one DSA that was greater than 3,000, but they were below the baseline level. And 1 patient had 1 DSA greater than 3,000 MFI and above the baseline level, the pre-imlifidase level. In terms of survival outcomes at the completion of the study, which again was 6 months, 100% of the patients had survived. The graft survival was 89%, 16 out of 18. There were 2 primary non-functions. These were both deceased donor recipients, and these were both deemed non-immunological graft losses, as these occurred in patients without any evidence of antibody-mediated rejection. And there's a little bit of explanation about some of these in the manuscript itself. These were both rather complicated patients. The first patient had profound autonomic dysfunction and hypotension, and that kidney just never recovered. And the second one, it's a little bit vaguely described, so I don't know much of the details here, but it's described as that the kidney was poorly perfused from the time intraoperatively. So I was suggesting perhaps there was some technical vascular issue that led to the kidney ultimately being declared primary non-function. Early graft function related to delayed graft function. So 7 out of 18 patients, or 39% of the patients, had delayed graft function. This was half of the deceased donors, 6 out of 13, and 1 out of the 5 living donors actually did also have delayed graft function, and that patient has had a severe early antibody-mediated rejection. The duration of DGF was pretty variable. It was as few as 1 day and was as long as 40 days in one of the participants. Rejection events were obviously of critical importance, given the propensity for rebound. 9 out of the 18 patients had a biopsy-proven rejection. The onset of these rejections were between days 3 and 167 post-transplant. 7 out of the 18 were antibody-mediated rejection or presumed antibody-mediated rejection. So about 40% of the patients had an antibody-mediated rejection. And these were all early. So the onset of the AMR was between 2 and 19 days post-transplant. The other 2 diagnosed biopsy-proven rejections were later. One was a borderline cellular rejection. I think that was diagnosed sometime around 100 days, but I don't remember exactly. And then the second was a subclinical rejection that was picked up on the 6-month protocol biopsy, and that was in the setting of normal renal function. All of the rejection events were treated with standard therapies, plasma exchange, IVIG steroids, and there were adjuncts that were given in severe cases like rituximab, eculizumab, bortezomib, and splenectomy, either surgical or functional. We'll talk about some of those details in a little bit. So in terms of renal function, the patients were grouped into those who had DGF and those who didn't have DGF, just to kind of parse out how that, if that impacted the ultimate function over time. There was a trend towards the patients who didn't experience DGF having improved long-term graft function, though I don't think that met statistical significance. The composite EGFR, median EGFR for the entire cohort was 47 at 6 months. And this is, of course, includes only the patients who had functioning grafts at that point, with a range of 21 to 92. Graft function also was mapped out by rejection status. So the patients who did not have any early antibody-mediated rejection, again, trended to have a better long-term EGFR than those who had early antibody-mediated rejection. And then the graft function of the failed grafts is kind of irrelevant. DSA rebound was assessed as to whether that seemed like it correlated in any way with antibody-mediated rejection. And this is sort of an imperfect analysis. But sort of one possible interpretation is that there wasn't any obvious correlation between rebound and actual antibody-mediated rejection. And this is just looking at the immunodominant DSA. the 6-month biopsy results, I don't want to really belabor this, but I think the take-home message here is that the chronicity scores at 6 months were low, and that's despite the fact that half of the patients had a rejection episode, and 40% of them had an antibody-mediated rejection episode, and then 7 of these patients actually had detectable DSAs at the time of the 6-month biopsy, but the CG scores were very low. This also was sort of incomplete data. There were only 12 of the 16 patients with functioning grafts that had the 6-month biopsies. I think that 4 of them were deferred due to just a not safe biopsy window. And then 2 of the biopsies were non-diagnostic and they were deemed too high risk to repeat. So there's only biopsy data at 6 months on 10 of the 16 patients. So this is kind of an outlier slide because this is data that's not presented in this paper per se, but this is a patient who was enrolled in the study at our center. And I put this in here just to kind of illustrate the rocky road that can occur when you're trying to cross these extremely high strength antibodies and kind of what that looked like when we have to add adjuncts to mitigate the rebound. So this was a patient who had extraordinarily strong class 1 antibodies. So this was an A1 and a B27 antibody, but just extremely high level antibodies. These were eliminated with imlifidase, but then began to rebound within about the first week of transplant. And this patient developed a very severe antibody-mediated rejection, was essentially anuric at this point, and had all of the adjunctive therapies available thrown at this patient, including splenic embolization, bortezomib, plasma exchange, eculizumab. And with this extremely aggressive therapy and treatment of antibody-mediated rejection, at about a month post-transplant, this kidney began to recover. The dialysis was able to be stopped. And the end of this story is that this patient now, 4 years and change out from transplant, has continued to have excellent graft function. So this is sort of like the extreme case of what happens in the setting of rebound. Safety data, again, I don't want to belabor this too much, but there were a total of 7 treatment emergent adverse events. Most of them were of mild grade. There were 2 that were considered serious or SAEs, and 1 was an infusion reaction that was able to be overcome just by slowing down the infusion. And then 1 was a cellular and a mixed cellular and antibody-mediated rejection that was for some reason attributed as possibly related to the imlifidase. But there were no grade 4 treatment emergent AEs. There were also no deaths during the study. And then with regard to the levels of anti-drug antibodies, that data aren't outlined specifically in the paper. It's just stated that it was consistent with previous studies, which is to say that basically all of the patients developed anti-drug antibodies, the rationale for not being able to repeat the dose in a delayed fashion in these patients. So in summary, with regard to the primary efficacy outcome, this was a very successful trial. The conversion of positive to negative cross matches within 24 hours was achieved in 94% of the patients. The 1 positive cross match was in the absence of donor-specific antibodies. So a little bit of a question as to what's driving that, whether it actually was a true positive or not. 18 extremely highly sensitized patients were able to undergo successful transplantation after imlifidase desensitization, and that is to say that's all who received at least 1 full dose. The imlifidase itself was well tolerated and the safety data were reassuring. Importantly, DSAs rebounded in many, but of course not all of the cases. The incidence of antibody-mediated rejection is similar to other desensitization studies, and importantly, no grafts were lost due to antibody-mediated rejection. So all of the AMR was able to be treated successfully. There were 2 graft losses, but they were due to non-immunologic causes, and graft function among the surviving grafts was overall acceptable/good, depending on where you draw the line. There are some limitations, of course, to this study. This is an open label study. There's no control arm. It's sort of difficult to imagine how a blinded study with this agent could be constructed. There's heterogeneity of both the subjects that enrolled in terms of the antibody spectrums, and as well as just the general complexity of the patients, and some of the outcomes, I think as evidenced by the PNFs, are confounded by recipient comorbidities. Likewise, in a study that includes living and deceased donors, there's significant heterogeneity of the donors, and some of the long-term graft function could be confounded by pre-existing donor disease in some of these deceased donors. The treatments for antibody-mediated rejection were at the discretion of the investigator, so those were also heterogeneous. There's incomplete 6-month biopsy data, and relatively speaking, there's short-term follow-up at 6 months, end of study. Speaking to that point, this is a paper for another discussion, but there is now available long-term data from these patients. This is a paper that was published in AJT several months ago. And this is sort of summary data from multiple phase 2 studies where the patients were followed out to 3 years. So all the patients included in this study are also included in this AJT study. And I just pulled out one figure here, which I think is the most important, and that's the cumulative AMR incidence. So basically all of the antibody-mediated rejection in these patients, which is a total of 39, occurred early. So there were no late antibody-mediated rejections in these cases. The agent, so the study isn't perfect, and the agent itself also clearly not perfect. No drugs are, but in this case, kind of the limitations to this drug as a desensitization agent include that rebound is common. And so when using this, you have to be prepared to look for and treat rejection. This study, the drug is also limited because of the propensity for recipients to form anti-drug antibodies. Therefore, you can't treat a delayed AMR with imlifidase. And finally, clearly some refinement is needed in terms of, this drug isn't necessarily for everybody. It isn't for every highly sensitized pair, regardless of what the crossmatch is. And that's kind of the reason why I illustrated that case of our patient, is that is probably pushing a bit too far what this drug is able to do. And so some refinement in terms of the protocols and who this drug really benefits most is forthcoming with further trials. And so I'm not going to conclude anything. That's sort of the job of everyone who's looking at this data to decide whether, imlifidase, it's a novel agent in desensitization, and is it going to be a game changer for patients now and in the future? That's for the community to decide. So I will stop right there. And I think we can commence our questions and discussion part of the Journal Club.
All right, thanks, Bonnie. It was a great presentation, very clear, very comprehensive. And we already have a lot of questions coming in, but for the audience, I'd encourage you to keep typing them in and we'll get to them as soon as we can. Bonnie, I want to start with my own question. And I think one of the criticisms of this study is going to be that it was a single arm, uncontrolled study. And I appreciate that you showed that case because it shows that how difficult it is to transplant these patients. And can you speak to some of the ethics of whether a controlled study is even possible in these types of patients? I can certainly tell you from our end that we probably took a lot of patients that we might not have transplanted without imlifidase. And can you speak to whether a controlled trial will ever be done?
Yeah, I can. So the answer is yes and no. There's not really a placebo-controlled trial that you could conceptually design, because it's very clear that giving nothing to the patients will result in a persistent positive crossmatch. There's also no way to blind that because it would be very clear what the treatment assignment was. So, and I think I can speak to this as there is a controlled, non-blinded, but controlled clinical trial that's in development, but it's sort of the structure of the study is a bit atypical. And it's, so rather than comparing a drug treatment to another, it's comparing the drug treatment to what would otherwise happen to the patients. In other words, standard of care. So you can randomize patients to either receive the drug or not. And if they receive the drug, great, they get the drug and they get transplanted. You follow their outcomes, or they're randomized to not receive the drug. And then they get, quote, standard of care, which is, do they get a transplant via cast? Do they get desensitization by way of plasma exchange and traditional desensitization therapies? Is that deemed impossible? And what happens to those patients in the long term? So that's sort of conceptually really the only way to design a controlled trial. At least that's all we've come up with.
Right. Thanks, Bonnie. Steve has a series of questions, but I think his most important of them is the rate of splenectomy used for control of rejection was 11%, one embolization, one splenectomy. Can you tell us a little bit more about how those rejections resolved? How long did it take for creatinine to return back to baseline in those cases? I know we presented one of those as the embolization case as well.
Yeah, it was highly variable. And I think, just speaking from experience in having several of these patients enrolled in the trial, I think our site enrolled 8 of the patients. We got better at this with time. With the first case, we didn't know when to expect the rebound, and we didn't know when to act on it. And so that case that I illustrated with the very severe rebound and severe rejection, that was actually the second patient that we enrolled in the study. And so we actually learned a lot from that case. And we sort of learned that it's probably better to intervene sooner, or at least start searching for the rebound sooner, so that we can, the sooner we treat the rebounding antibody, the less likely it is to be beyond control and require such aggressive maneuvers as splenectomy, et cetera. So I think it was highly variable, just on the basis of how high the antibodies rebounded, because that wasn't consistent across patients. But it also evolved with sort of investigator experience with the study and this brand new agent over time.
Ed, if you don't mind, I'm just going to piggyback 2 relevant questions on the back of that are short. The first of which, Bonnie, is can you describe the class 1, class 2 distribution of rebound, and whether or not you would have done anything differently if you were to have redesigned this experience to empirically try to prevent rebound?
Yeah, so interesting. Again, it was a relatively small study, only 18 patients, but there were just no patterns. I think we were all really hopeful that we would be able to extract from this that, okay, class 1 antibody is at much higher risk to rebound, or this specific antibody, but it wasn't true. We saw some patients who had a high class 1 and none of it rebounded. We saw vice versa. We saw some where class 2 only and not class 1 rebounded. There was just nothing that we could, there were no correlations that we could make, at least with this sample size. And so I think, the only thing that I would do differently in retrospect would be to do earlier biopsies for cause. So have a very low limit, a low threshold for actually treating patients when we start seeing the rebound, and actually starting to look for the rebound early, because the sooner we saw that, the sooner we treated it, the better the patients were off. Now, that having been said, there were some patients who had significant rebounds and no antibody-mediated rejection on biopsies. So the answer isn't just to start pheresing everybody who has rebound. It's, in my opinion, to do an early biopsy and see if you really have an entity that requires treatment and initiate that treatment promptly.
Bonnie, there's a question here requesting clarification. 5 patients had class 1 DSA greater than 20,000 MFI, and the question is, do you have information on how strong were these cross matches, and were these patients more likely to rebound than weaker antibodies?
Yeah, that data exists, but I am not privy to that data. It wasn't illustrated sort of patient by patient in this report, and so I can't answer that question with the data that I have. I don't have the entire multi-center data set. I only have our own. And as I sort of alluded to before, there were no patterns to it. We saw some patients with extremely high class 1 antibody, and this one patient had no rebound whatsoever. It was a mystery. We didn't know how people were going to behave after this. It was just kind of take it as it comes.
There's another question, Chris. I'm going to take this one and I'll give you the next one. Someone is asking, in your experience with plasmapheresis, that how does this compare to imlifidase compared to plasmapheresis, and what would you say?
Yeah, so the short answer is it really doesn't compare. The amount of time and the number of plasma exchange treatments required to reduce antibody from some of the strengths that we saw to what imlifidase would achieve. I mean, that would take probably weeks in our experience, if it was even achievable. These high strength antibodies really disappeared in a time frame of hours, and that's obviously not accomplishable with pheresis, which is a very inefficient means of clearing IgG, at least.
Yeah, I just, me personally, Bonnie, I struggle with the short duration of effect. You know what I mean? But yes, your point is exceptionally well taken. Curious your thoughts on the distribution of sex in the 18 patients that were enrolled in the study, knowing most of us end up with a female-dominated, highly sensitized list, but seeming to have a few more males enrolled in the 18. That may just be artifactual, even the small n, but curious if you have any additional thoughts on implications of sex.
Yeah, I don't, other than to say, I noted, and I think as larger scale studies are taken on, probably attention needs to be paid to are there discriminatory practices, either consciously or unconsciously, in who we offer these innovative therapies to. I hope the answer to that is no, but I don't think we can conclude more from this small number than it was just that trend, but something certainly worth keeping an eye on in the future, for sure.
There's a question here, Bonnie, about future directions for imlifidase. One of them being, if you could speak to the studies that are going to be going on for its treatment for antibody-mediated rejection. But I also think it would also be relevant to ask you, it seems like all of these patients who are being enrolled in the desensitization trials are the most difficult patients. And is there a role to expand it out to people who are less high risk?
Yeah, sure. I can speak in a limited fashion to the ongoing trials. Mainly, I can say that there is a currently enrolling trial for imlifidase for the treatment of AMR. Clearly, this enrolls only patients who were not desensitized with AMR. And I can't really speak to any of the preliminary data, but hopefully within the next year or two, we will have that available to us. And then as to your second question of kind of broadening the eligibility criteria and not restricting this to being able to transplant the most difficult to transplant patients, yeah, by all means, I think absolutely. Some of this is regulatory nuances and what trials really have to be done in order to convince the regulatory agencies that this product deserves an indication. And that is to some extent driving the enrolled patient population. But if you're talking about an agent that's much more efficient and much easier to administer than plasma exchange, there's no reason why this couldn't be used for simple ABO incompatible transplants where there's a low antibody titer, or for just kind of a flow cross-match-positive live donor pair that they really want to go together. Why wouldn't a pair like that be eligible for this, as opposed to being mandated to go into a paired exchange, or having to undergo a week of pheresis before the transplant? So yeah, I think it's an alternative that hopefully will be available to be used in more applications than just these patients who are otherwise have no options.
Bonnie, curious on the protocol biopsy at 6 months, curious what level of intensity was performed looking for AMR. Was EM routinely performed at the 6 month biopsy? And do you have any information about the degree to which, fortunately read by a single pathologist, but the degree to which sort of advanced testing was done on that 6 month biopsy?
Yeah, I should know the answer to the question about EM, and off the top of my head, I do not. I'm sorry. I don't know. I think so, but I am not completely sure.
Gotcha. And then the last question, I think relevant, particularly to the pharmacists in the audience. Curious if you could just refresh the kinetics of anti-imlifidase antibody formation and the implications therein for repeated dosing, and how the 24-hour interval was defined.
Yeah, so it was a 2-day interval. And that was very conservative. So the anti-drug antibodies definitely don't appear that fast. And the data describing the anti-drug antibody emergence kinetics are in the phase 1 trials. And so again, this is just from memory, but I think it was not sooner than around a month. 3-4 weeks would be about the soonest that it was seen. It certainly wasn't seen within a week, but the 2 days was just a conservative time frame.
Bonnie, I think we have time for one more question, so I'm going to give you this last one. Someone asked a question about any thoughts about non-HLA antibodies in AMR and rebound DSA.
Meaning, would this be something that would be effective to use in that case, or or are we worried about, is there AMR caused by some antibody entity that we're otherwise not measuring with the Luminex assay?
Right. I think they may be getting at whether or not this might have some non-specific benefits in maybe antibodies that we can't measure or even appreciate.
I see. Yeah, I mean, I think it's theoretically possible. This is a non-discriminatory agent. It cleaves all IgG, all subclasses of IgG. And so we've all seen those patients where they have a positive cross-match, but they don't have any HLA antibody. And so we're assuming they're endothelial antibody or AT1R antibody, and we have limited abilities to quantitate those. And so, yeah, I think that would be a small, but a group of patients where the application of this drug might be of benefit. Yeah. It always helps to have something to be able to measure, though, I have to say, post-transplant.
Right.
Because you know it's coming back, or you know there's a strong likelihood that it's coming back.
Yeah. All right. Well, we're at the top of the hour. Bonnie, that was a great presentation. Thanks for all your expertise. Chris, it's a pleasure to co-moderate with you. And thank you, everyone, for attending. I'm going to turn the mic over to Brian to close out.
Thank you, Dr. Huang. AST would like to thank Dr. Lonze, Huang, Ensor, and all of our attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's communities of practice, please visit myast.org/COPS or connect directly to the Kidney Pancreas Community of Practice and Transplant Pharmacy Community Practice Hubs. Thank you all again for today's great session.